Hi, thank you very much, Ed. I'd really like to thank all of you for joining this evening. I'm really excited to talk to you about NovaVision. I first was introduced to vision restoration therapy probably around 10 years ago before NovaVision formed. There's an annual meeting that I always attend called ARVO, Association for Research in Vision and Ophthalmology. And in walking around the many thousands of posters one year, I found some postdoc presenting something on a way to treat hemianopia. And as a neuro-ophthalmologist, I see a large number, and we have never had a way to treat that. We got to talking, it was very exciting, and we met again the next year, and then she disappeared. I found out later they were forming this company, and when they came back, I was excited to see what they were doing. I got involved in it, have been using it with my patients, and I'm just as excited about it now as I was when I first heard about it. I'd like to tell you a little bit what I've learned. Vision restoration therapy basically is a treatment that we have now of increasing our ability to visually rehabilitate these patients with visual loss from acquired brain injury. And the brain injury type that we're dealing with, it doesn't really matter. Certainly the most common is stroke and traumatic brain injury. I've also used it in patients with brain tumors that have been removed or injuries post-aneurysms, infections, and surgeries. All of these, it doesn't really matter what the underlying process is. When we think about it, it's worthwhile to try and sort out anatomic defects from functional defects because they can be very different. And anatomic defects can occur without any functional change. And you can also have functional changes without any obvious anatomic defects. Vision doesn't show up very well doesn't have a large vision area, but most people do. And there can be many different visual effects from acquired brain injury, and these include such things as perhaps color vision defects, ability to recognize faces, ability to recognize objects, even to detect motion in different directions in space. But really, of all of these, the most devastating is the visual field loss itself. The others may occur with or without field loss, but it's just the field loss that really makes a big difference. Okay. And the different patterns of field loss, as you can see, depends on where the injury is. So you can have optic nerve injuries that affect vision, chiasmal problems, and anything in the radiations or the optic in the visual cortex. And it doesn't really matter what type of lesion it is, what type of pattern of visual loss. All of these can actually be treated by vision restoration therapy. So whether you have scotomas or altitudinal defects from optic nerve problems, quadrant synopic defects, hemianopic defects, or even I've treated a patient with total hemianopia and a quadrantopia. So all of these, it can be very helpful. So actually, if you think about it, my first reaction when I first heard about vision restoration therapy was, how could this be possible? I mean, we had talked about different treatments when I was in medical school, and we really taught that the brain is a hardwired structure. And after it's injured, you may have some recovery of cells that are only partially damaged, but after a period of time, that stops, and there's nothing that the brain cells can do. We were taught that there is no regeneration of these brain cells, and that they did not form new connections. So the only treatment we had for hemianopia was to try and encourage the patient to become more aware of his surroundings, so to get them to develop more saccades into the blind field. For a while, and some people still are using prisms. They put different sizes of prisms on glasses in front of the person, so it actually shifts the blind field into the seeing field. My experience was that these are people with brain injuries, and they had enough problems with confusion without moving one field on top of another. And I did try it a number of times, and it very rarely was helpful at all. We really didn't have a lot to offer these patients. But now it's been clearly shown from a number of animal studies and human studies the adult brain actually has a phenomenal ability to deplastic, develop new connections, form new circuits, and also, most surprisingly, is actually new nerve cells may be formed. And this ability to have plasticity develop is maintained well through in older age people. And like I said, this has been shown not only for vision but for motor function in animals as well as people. So let's talk a little bit about NovaVision specifically and how it works. Basically, vision restoration therapy by NovaVision, they call it a light-based neural stimulation. I assume that was for FDA regulations. But anyway, so they use light to stimulate the visual system and the brain. And they have a very sensitive way to map the visual function with a computer program. And what this does is very accurately define the area of the person's visual field defect. So that will be different for every person. We tend to think of a hemianopic defect as just a straight line through the middle, and sometimes it is that if it's very total. But very often that line is a little wavy and it moves around, and it is not an absolute defect. It's partial in some places and absolute in others. And so they're able to map the actual extent of each person's defect fairly accurately. And they then define a specific therapy program based on each individual's loss. And so they work it out so that right along that area, that boundary area between seeing and not seeing, that's where they're stimulating constantly. And the therapy is done at the patient's home. He does it himself in his own environment, and it's called for 2 sessions a day at about 30 minutes per session. Sometimes, depending on the patient's ability to concentrate for that period of time, we've broken up into more 15-minute sections. But generally, it seems that it takes a good 15 minutes of concentrated effort to get a good response. Okay. Patient selection and screening is extremely important because a lot of patients come in with different expectations, different ideas. So visual restoration therapy is good for anybody who has suffered from a brain injury and has visual field loss as a result. It doesn't necessarily have to be the brain itself, but also optic nerve. Optic nerve is also very responsive to this treatment. They do have to have at least 2200 visual acuity to be able to fixate. I mentioned that they plot the visual field very accurately, and so if the patient is moving their eyes back from one place to another, the defect is no longer exactly where the machine thinks it is, so the person has to be able to stare right in the center and keep his eyes fixed on that target as well as possible. If the person has some degree of dementia, obviously that's a lot harder, and a lot of these people actually cannot do this test. If they have some type of problem with attention deficit, again, or decreased cognitive functions, they don't understand or don't remember that they have to keep their eyes still. All of these will interfere with function, and basically this is easy to assess in the office, and usually we can screen them out. It's not hard to screen them out fairly early. Most of these patients are very excited about the therapy and really can cooperate fairly well. Obviously, you have to sit up and be able to push buttons on the computer as well, again, for the 30-minute session. Who the therapy is not for. Again, I mentioned people come in with some unrealistic expectations that have to be addressed. Medical contraindications, I guess, again, the FDA, I guess, requires saying photogenic seizures, how one spot of light delivered every few seconds is going to seizure is beyond me as a neurologist, but whatever. Progressive problems is also something that would not be recommended because the visual defect is not stable, and the brain's response to defect, if it's trying to learn something, you'd expect it to want to try and learn something to a stable condition. So if they have a progressive problem, the baseline is trying to be corrected is constantly changing. So they should have a stable problem. There are people who come in thinking, oh, I've heard of a way that I can see better. Can this help me? I don't want to go for the laser vision therapy, the laser therapy for refractive error. That even people that have true hemianopias, the reason that they want to do it a lot of times is they just say, I want to drive again. And I usually spend a lot of time talking to them about that, because if they're not having other problems, I tell them they really shouldn't do it. It's too much effort. NovaVision is not set up to make this hemianopic defect disappear. It's designed, and it does very well, to make it bigger so that it makes the person much more functional and they feel better, they feel more confident in the world, but whether or not they can drive again is not something at all that you can encourage in that patient. And if they can't do that, you don't want them to feel that they have wasted their time, even though their vision may be somewhat better. Again, if they can't do treatment, we talked about an inability to sit and fixate and concentrate for 30 minutes at a time. So cognition and poor fixation would be contraindications. Dealing with patient expectations, I mentioned, unfortunately, this doesn't work in everybody. Why it works or why it doesn't work in a given person is not something that we have any data at all about. In my experience, I reviewed the patients that we had, about 65% of people actually are very pleased and think they are much better, and that's pretty much the result in the literature and other people that I've talked to. But that does mean a little more than a third of patients do not get better, and they just have to be made aware of that before the start. The other thing that can be discouraging, so it's important that they know beforehand, is that you seldom see any change before 3 months. Sometimes you do. Sometimes you can get remarkable changes in 6 weeks or so. But in general, I tell them that you really have to do this twice a day, 6 days a week for several months, 3 months before you'll see any change, so that they should not get discouraged. And I mentioned why this is from person to person. We really don't know. I do remind them that it's not simple. It does take a lot of concentration. Some people might ask, well, if I did it 3 times a day, will that be better? As best as we can tell, no. That is not useful. It's not useful to do more than a half hour at a time, and more than an hour is not something either that has been shown to be of any benefit. What we're doing is training the brain. It's like us sitting in a lecture that we really want to learn from and concentrate on, and if there's noise and changing environments, we're not going to be able to concentrate on the lecture. And similarly, the brain can't concentrate on learning what it's supposed to see if the environment is not conducive to that. What goes on with the VRT process itself when you start? So basically, if you have someone that you want to undergo vision therapy, he gets evaluated, or he or she gets evaluated, and they should be screened, as we talked about, for an ability to undergo this therapy, so that they really have very realistic expectations, and everybody agrees, the physician and the patient agrees this is for them. And what happens is they get this device, and it's sent to them, and we usually show them how to do it for the first time in our office, but some people who are very computer savvy, they just have it sent right to their house, and they set it up and use it. It's very simple. And the way that the therapy starts is that they do this very sensitive visual field, the computer does, and they do 3 diagnostic tests. That information then gets sent to NovaVision, and it's analyzed, and the specific field defect of that patient is determined, and a therapy strategy, again, specific to that person's defect, is sent back to the patient. With that, then he sits at his device and starts the 6-day-a-week treatment, and he starts doing his therapy on a regular basis. Every month, that information, how he's been doing, goes back to NovaVision, and they reanalyze the field defect and then change the therapy based on the results of the last screening. So, so should the patient do better, then they change the boundaries that the therapeutic stimuli are testing constantly. After the therapy is done at 6 months, we review, or we review intermittently in between as well. But at 6 months, that's a general course, and you review with the patient how they feel. And the patients that have gotten no benefit, generally I've not encouraged them to go any further. If they feel that they've been getting continual success and we go over the results together, a number of patients tend to continue the therapy for another 3 months. But that's very individualized depending on the patient and how they're feeling about what it's doing. Again, the literature is pretty consistent. Somewhere between 65 and 70% of people show improvement, and this has been in about over 1,500 patients that have been treated at this point. I don't know the exact number. It seems that working at that specific boundary area and the intense stimulation of twice a day with high concentration is a big key to the success of this treatment. So how does this work? We don't really know. To some extent, there's what we think, and there's evidence for this on fMRIs that I'll mention later, that the visual field itself does enlarge. But it's clear in looking at the visual field and the patient's reaction that that's not the only thing that happens, because they don't always correlate for some reason. There's patients who develop improved reaction time to stimuli, and they seem to sense stimuli. They don't bump into things, even though their visual field is not markedly increased. They bump into things less, they say. They're much more confident and they're happy about what they see. So it has something to do not only with the actual conscious visual field, but I suspect that there's also an improvement in the and more unconscious awareness of the vision, a kind of a blind sight type of thing. These are just some examples of some cases had. This is a fairly dense defect. This is a 53-year-old woman who suffered a hemorrhage, and this is after the treatment. Notice the lesion age at onset of the treatment is almost always prolonged. The year is fairly short. Often they start after 2 years or 5 years. The initial study purposely was set up to take patients on who had their damage many years earlier, so that people wouldn't say, oh, this was just the natural history of the condition. So we see it really doesn't matter how long it's been since the injury. And this is a good result. We see that there's somewhere between a 5 and in this area a 10 to 15 degree improvement in the visual field inferiorly. And this ballooning out in a little section is something that I see really a lot of the time, not most of the time. If there seems to be like a little hole, it just kind of carves out a bigger and bigger section out of that visual field. Yeah. This is another case, a 61-year-old gentleman who had a stroke 3 years before. And again, this is an example of the little increasing of the holes that might be there. And the same thing's happening even if it's total. It might make a little hole and it will increase from that little area, as opposed to increasing. The whole field doesn't move over most of the time. Usually it's in these little sections. This is a fairly typical comment from a patient. After my stroke, I lost about half my field of vision. And since starting VRT, I've noticeable improvements in my vision. I see more. It's easier to read. I can see the entire TV screen while watching TV, and even enjoy going to the movies more. And like I said, that's fairly typical. Some of the things I tend to ask about the patients before we start is how difficult is it? Do they have trouble reading? Do they bump into things? Do they lose things on their plate? These are things that one can expect to get better after this treatment if they're going to respond. This was an unusual example, but we've had several of them. A patient who had a severe hemianopia. That was a number of years before, so clearly this is not spontaneous. And after treatment, the field has markedly improved. So it's very striking. And also in these patients, if they're retested, the defects are permanent. There's been no cases that I'm aware of that the patients have lost any improvements that they've gained. So in the past, before we had anything like visual restoration therapy, we would send them to OT and for rehab, and they get their occupational therapy and physical therapy and whatever, and it would help to some extent. But now we actually have another pillar to help in this neuro rehab and vision rehabilitation therapy, I think, really can make a tremendous difference in these patients' lives. Happy to take any questions that anybody might have.
Dr. Rosenberg, what's a realistic outcome for this therapy? If somebody comes to your office, is there a way on a general basis to make an assumption of what the possible positive outcome might be?
Well, I tell patients when they ask me that, basically that I say 65% to 70% of patients feel that they are able to get around better in the world. They feel more comfortable at what they're seeing. They may be able to read a little bit better. I'm careful who I say that to because not uncommonly patients with hemianopias, particularly right hemianopias, may have alexia as well. So careful who I will say they may do better at reading too. And I also am careful to say that they should not expect to drive again, although that's possible.
Okay, so when you're doing this assessment, what factors are you looking for that might indicate a positive outcome? Are there certain things in particular in your workup and diagnosis that tells you that this patient may have a good outcome and this patient might not?
Yeah, I wish. Unfortunately, other than screening out people who can't concentrate, there's not much. If the person, even though they are able to concentrate and they are able to fixate and they do the therapy religiously, a certain percentage still don't get better, and they have looked at whether or not it has to do with the size of the lesion, the severity of the defect, the shape of the defect, and to my knowledge there has been no evidence that there's anything to predict who's going to get better and who's not. Even after 2 months, you can't tell, because I've had people who seem like they get nothing for 2 months and they get discouraged, and we talk to them, and then after 3 months they really start to get better. So there's no way to predict.
Okay. We have some questions from the audience. The first one is, let's see, are the visual field gains, are they permanent?
Yes. Yes, they do seem that. There's been studies that we've done patients several years afterwards, and I think NovaVision has several examples. I'd be happy to talk to anybody if they wanted to call me. I can only say this has been very exciting for me to be able to have something to offer to my patients.
Thank you for watching the webinar presentation featuring Dr. Rosenberg. For more information on NovaVision, contact us at 1-888-205-0800 or visit us at www.novavision.com.